A very good evening to the respected directors, panelists, and one and all present here. My name is Adarsh Chandramouli. I'm a second year MBBS student from Madras Medical College, and I'm here to present a case which I've titled When Immunity Fails, a case of disseminated CNS aspergillosis in a suspected primary immunodeficiency. The following case has been taken from the Institute of Internal Medicine, Madras Medical College, and Rajiv Gandhi Government General Hospital, and formal permission was taken from the faculty overseeing the management of this patient. Now, moving on to the case, a 19-year-old male from Tirupur, Tamil Nadu, a student, were presented to the OPD with complaints of weakness of the right upper limb and lower limb for the past 2 months, difficulty in walking for 1 week, slurring of speech for 3 days, and an episode of vomiting the previous day. The patient was admitted to the ward on 30th of March 2026. Now, coming to the history of presenting illness, the patient was apparently normal until 2 months ago when he developed complaints of weakness of the right upper limb, which manifested in a difficulty in writing. This weakness was gradual in onset and involved mainly the distal muscles. Fine motor functions were affected, but the gross motor functions were retained. The patient also had right lower limb weakness, difficulty in walking for the past 1 week, which was gradual in onset, and had occasional episodes of falling to the right side. This was accompanied by leg pain. Now, the patient also had headache for the past 1 week, which was gradual in onset, diffuse in nature, dull aching in character, and there was no radiation of visual disturbance. This pain was resolved by medications. The slurring of speech was present for the past 3 days, and he had an episode of vomiting the previous day, which was projectile and non-bilious in nature. Now, coming to the past medical history, this patient was diagnosed with endobronchial fungal infection. A bronchoscopy and cryobiopsy had been performed on 23rd of July 2025 at Government Medical College, Tirupur. This revealed presence of fungal filaments of Aspergillus fumigatus and Curvularia spicifera. And for this, oral voriconazole was prescribed for 2 months. However, the patient compliance was irregular. There was no significant family history. And coming to the personal history, the patient had a mixed diet, consumed both vegetarian and non-vegetarian cuisine. He had normal sleep, normal bladder and bowel movements, and there was no history of smoking or alcohol intake. Now, coming to the examination of the patient, which begins with the general examination. By appearance, the patient was conscious, oriented, well built and nourished, and afebrile. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, and the vitals were normal. Coming to the CNS examination, bilaterally the pupils were equal and reactive to light, and the extraocular muscle movements were full. However, on fundoscopic examination, the disc margin was blurred, and there was papilledema. This indicated increased intracranial pressure. There was no facial lag, which excluded the possibility of a facial nerve palsy, and dysarthria was noted, which was of upper motor neuron spastic type. Tone and power were examined, and when the tone was examined, it was noticed that right upper and lower limbs had reduced tone, but the tone of the left upper and lower limb were normal. The power was slightly reduced in the right upper limb and lower limb, while the power was normal in the left upper and lower limbs. The grade of power on the right upper and upper limb was 4, and that of lower limb was 3, and the grade was 5 for both the left upper and lower limb. Deep tendon reflexes were elicited of both the upper and the lower limb, which included the biceps jerk, the triceps jerk, the knee jerk, and the ankle jerk. In all four reflexes, what was noted was the reflexes were slightly depressed in the right upper and lower limbs, but the reflexes were normal in the left limb. Plantar reflex was elicited, and an extensor plantar reflex, that is a Babinski sign, was positive in the right lower limb, but a normal response was seen in the left lower limb, indicating a lesion of the upper motor neuron right. There was no neck rigidity, this excluded the possibility of meningitis, and the sensory nervous system, cerebellum, and the autonomic nervous system were all found to be normal. The other systems were examined, and the respiratory system examination revealed crepitations and an occasional wheeze heard in the right mammary and infraaxillary regions, occasional crepitations in the left infraaxillary region. The cardiovascular system examination was normal. Now, from this history and clinical examination, a provisional diagnosis of probable disseminated aspergillosis with endobronchial and CNS involvement was arrived at. Now, the next step was to find out the reason behind such a dissemination, which is extremely uncommon in a patient of 19 years, extremely young. The differential diagnosis, the next differential after this was CNS tuberculoma, because TB is an extremely common disease, especially in our country. And CNS tuberculoma also has a similar clinical presentation. And such an infection always increases the possibility of an immunodeficient stage, which could mean opportunistic infections also are a differential. So after this, a diagnostic workup was done, which include laboratory investigations, microbiological investigations, and imaging. The first imaging study performed was the CT test, which revealed right lower lobe patchy opacities, which progressed into consolidation. This is the CT scan. Ma'am, could you please confirm if the pointer is visible, ma'am?
Pointer is not visible.
Yeah, it's
Pointer
now,
is
ma'am?
Yeah,
Yeah,
now
it
it's
is.
okay. Yeah.
Yes, ma'am. So the right lower lobe patchy opacities can be seen here, which progress into consolidation. After that, the next imaging study performed was the MRI of brain, which revealed multiple, more than 10, ring enhancing, supratentorial, and infratentorial lesions with thick nodular enhancement, intracavitary projection, and extensive surrounding edema. These point strongly to a fungal abscess in the brain. So, this is the MRI scan which reveals these findings. After this, a CT brain was done, which revealed, excuse me, the CT brain revealed multiple heterodense lesions with perilesional edema. So this is a CT scan. After this, microbiological studies were performed. The sputum KOH mount revealed no fungal elements. A sputum AFB was also performed to exclude the possibility of tuberculosis, and this result arrived negative. We suspected an immunodeficiency, so we wanted to rule out HIV. So an HIV antibody test by rapid method was performed, which was also negative. So this raised the possibility of a primary immunodeficiency. Thus, a full immunoglobulin profile was performed, which also included flow cytometry studies. Now, the serum IgG and IgE levels were both elevated, and by flow cytometry, the absolute count of the NK cells was lower than normal. It is only 37 cells per microliter, whereas the normal count is 82 to 760. After this, the dihydrorhodamine test was performed to find out the proportion of patient granulocytes showing oxidative burst. This was found to be 57%, which is abnormally low. After this, the nitro blue tetrazolium, that is the NBT dye reduction test, was also performed by flow cytometry, and it was noted that the dye was preserved in approximately 50% of granulocytes of the subject. This is also abnormally low. Now, the dihydrorhodamine test and the nitroblue tetrazolium dye reduction test studies point towards chronic granulomatous disease, because these indicate decreased neutrophil oxidative burst function. After this, a thorough genetic testing was performed to find out any genetic abnormality that may have contributed to this immunodeficiency. And no significant variant, that is, no single nucleotide variant or copy number variant, which is related to this particular phenotype, was detected. So after this, it was concluded that the NK cell deficiency was an incidental finding, and the main cause of the immunodeficiency of the patient was chronic granulomatous disease. Now, coming to the final diagnosis, it was probable disseminated invasive fungal infection with endobronchial and CNS involvement, most likely due to Aspergillus fumigatus with possible Curvularia spicifera co-infection in a patient with underlying chronic granulomatous disease. Now, these are the key findings which support the diagnosis. There was a proven pulmonary fungal infection because an endobronchial biopsy performed a year ago showed Aspergillus fumigatus and Curvularia spicifera. MRI brain findings also strongly favored fungal abscesses, multiple lesions, thick nodular enhancement, intracavitary projections, and extensive surrounding edema. This showed a dissemination pattern. And finally, immunological evidence supported the susceptibility because flow cytometry suggestive of CDD strongly supports a predisposition to invasive aspergillosis. Now, the treatment. The patient was first prescribed liposomal amphotericin B for 5 weeks for a dose of with a dose of 5 milligrams per kg per day, and renal function tests were regularly performed since liposomal amphotericin B is known to be a highly nephrotoxic drug. One of the most common side effects is hypokalemia, and hence one episode of hypokalemic crisis was recorded in the ward. However, it was corrected soon by fluids. Finally, at discharge, voriconazole was prescribed to the patient. Now, the clinical course. The patient was administered liposomal amphotericin B for 5 weeks. Initially, the infection did not resolve, but gradually improvement was seen on the CT scan. Finally, in the 5th week, the patient and the attender unfortunately demanded to be discharged, despite the course of the treatment not being complete, because the conventional treatment regimen lasts for at least 6 to 8 weeks. The patient was advised about the importance of completion of the treatment, the full course of the treatment for 6 to 8 weeks, but finally, the autonomy and wishes of the patient were respected, and he was discharged on the 5th week and was prescribed voriconazole. This is the final CT brain taken, which indicated an improvement in the condition. So, as we see, the number of lesions have greatly reduced. There are a few lesions seen, but they have significantly decreased in size, and the extent of perilesional edema has also reduced. Now, the key takeaways from this case. Here, I would like to take this opportunity to discuss a bit about chronic granulomatous disease and how it can contribute to invasive aspergillosis. Now, chronic granulomatous disease is fundamentally a decrease in the oxidative burst capacity of the neutrophil. Oxidative burst is a mechanism by which the neutrophil makes use of an enzyme called NADPH oxidase and produces hydrogen peroxide and a number of reactive oxygen species, which can in turn be used to attack pathogens entering our body, such as various bacteria and fungi. Now, as we know, infectious organisms can be classified in a number of ways. One of the ways being whether they are catalase positive or catalase negative. Now, catalase negative organisms lack the catalase enzyme. Hence these organisms produce hydrogen peroxide, which can in turn be used by the neutrophil to carry out its oxidative burst function. However, in catalase positive organisms, the hydrogen peroxide is broken down by the catalase enzyme. Hence, there is no hydrogen peroxide or reactive oxygen species available for the oxidative burst function. This is the reason why chronic granulomatous disease especially increases the predisposition to catalase positive organisms like Aspergillus fumigatus in this case. Now, disseminated aspergillosis with CNS involvement can occur in young patients without obvious classical immunosuppression. It can also occur in patients with HIV, transplant status, steroid use, and if all these parameters are negative, it should lead to prompt evaluation for underlying primary immunodeficiency, like in this case. MRI features such as thick irregular walls, intracavitary projections, and extensive perilesional edema may favor a fungal etiology. Chronic granulomatous disease can present later in adolescence or adulthood, and negative genetic testing does not completely exclude the diagnosis when functional assays are suggestive. Here, I would like to add the point that among the NBT and the DHR test, the dihydrorhodamine test has been established as a gold standard as it is a much more sensitive and specific test for chronic granulomatous disease. And finally, tissue diagnosis and clinico-radiological correlation are crucial in invasive fungal disease, as negative sputum fungal studies, like in this case, do not exclude disseminated infection. Now, at this junction, I would like to first thank the esteemed members of the Madras Redford Doctors Foundation for giving me this opportunity to present this case. I would like to thank the esteemed panelists for spending their valuable time in assessing my presentation and guiding me on improvements to be made. I would like to thank Dr. T.S. Shanti Ma'am, Professor, Institute of Internal Medicine, and the Unit Chief, Dr. Sendilpriyan K., Assistant Professor, Institute of Internal Medicine, and Dr. Mukil S., Assistant Professor, Institute of Internal Medicine, for their guidance and support. These are the references. Thank you and have a nice day.
Thank you, Adarsh. So over to the judges.
That was an excellent presentation. I enjoyed it very much, and it's very educational. Also, learned a lot. A lot of it went over my head. I haven't heard a lot of these terms. Um, so very enjoyable. So, what is the incidence of this particular disease you were talking about?
Aspergillosis per se is a relatively common condition, especially in areas like Tirupur, which have many cotton mills, which are a breeding ground for fungal spores. But aspergillosis, especially of the disseminated variety, is extremely uncommon in a person of 19 years. And because most commonly people with disseminated aspergillosis end up being patients who have either HIV or have recently undergone a transplant or are on immunosuppressants. A case of chronic granulomatous disease with aspergillosis is a relatively rare presentation, sir.
Thank you. All the best to you.
Thank you, sir.
Okay, so Adarsh, once again, an excellent presentation. I also enjoyed it. A
Thank you, sir.
very thorough presentation. So there are two main aspects to this case. I'm a neurosurgeon, so naturally I was attracted to the CNS part of the case, which is not as complicated as the underlying immunology part of this case, which is more complicated and which I understood less well. To start with, this patient is a 19-year-old previously healthy person, right? And in a
Yes, sir.
19-year-old, he presents with pulmonary fungal infection. And in no time at all, this has spread to the brain. And in fact, when I saw those brain scans, both the CT and MR, it was quite scary. There are multiple lesions with a lot of edema. And you clearly told us in your presentation that the patient already had papilledema, projectile vomiting, headache, right hemiparesis, dysarthric speech, all of which indicates a significant increase in the intracranial pressure. And,
Yes.
and another problem of having these lesions is they are extremely irritative, and these patients often have seizures, epileptic attacks. And if you have multiple lesions like this, and on top of that, the patient has a grand mal seizure, at the end of that seizure, they usually end up being herniated and more or less die from it because the seizure causes an acute increase in the intracranial pressure in addition to the chronic increase in intracranial pressure from these lesions. And did you ever consider giving him some cortisone, some type of steroids, in addition to the antifungal treatment to reduce the intracranial pressure? Was that a consideration, Adarsh?
Mm, Not really, so we didn't consider the possibility of administering cortisol.
Yeah, because that is, it is the fungal infections are extremely irritative. And of course, I know all the side effects of giving cortisone to this patient, but it is only to be given with antifungal treatment. And I only mentioned it because because in your presentation, the patient had papilledema, projectile vomiting, headache, and all this indicates significant increase in the intracranial pressure. And as I said,
Yes, sir.
the MRI scan and the CT scans were extremely impressive. I mean, these are big lesions with a lot of edema, and I was very
Yes.
concerned about that. Um, I saw the follow-up CT scan just prior to discharge. I mean, it's not your fault that the patient left against medical advice before the treatment was completed. And there was certainly a dramatic improvement in the scan compared to the earlier scans. But to a certain extent, you cannot compare the earlier scan with this scan because it was done in a different way, and it is not MRI versus MRI. It was CT scan. I'm delighted that he survived and did well. And the question I have is, how is his immune deficiency being managed? Can it be managed? Can something be done for that? Because if not, as soon as you finish this antifungal treatment and everything, there is a likelihood that he could come back with a recurrent infection, correct?
Yes, sir. The
So,
possibility of a recurrence remains a high possibility because of his underlying immune conditions.
yeah. So, is there anything that can be done for the immune deficiency itself?
So here the primary deficit lies in the NADPH oxidase enzyme within the neutrophil, sir.
Okay.
So in this condition, it's not just a decrease in the neutrophil count; it's the decrease in the oxidative burst capacity. So replacement of that function is extremely difficult to the normal
Okay.
levels, sir.
Okay. Is there any family history? Is there any other members of
No, sir.
family? No. So
No, sir.
this is
Absolutely no family history, sir.
so this is a sporadic, isolated incident of this. Okay.
Yes, sir.
Look, and also, did his neurological findings improve as he was treated? His right hemiparesis, the speech difficulty, papilledema, did all these things resolve?
Yes, sir. Yes,
Okay.
sir. His speech became better and his right upper and lower limb weakness improved, and he was able to walk much more stably without tilting to the right. So,
All right. Look, I enjoyed your presentation and thank you very much. It was you did very well. Thank you.
thank you, sir.
Okay. Thank you, sir. Can we have Dr. Jayavelan, please?
Hello, Adarsh. It's a
Good evening, sir.
presentation.
Thank you, sir.
It's very common to have aspergillosis fungal infection in Tilpuri area because of the cotton dust. But it is very, very unusual to have this disseminated to the brain. And it's a clear-cut case of aspergillosis spreading to the brain without immunodeficiency. We have seen some cases where the immunodeficiency is there, they are getting the infection. But this young man getting infection is very rare. The presentation was very good. Thank you. All the best.
Thank you, sir.
Thank you, sir. Can we have Dr. Vijay Shankar, please?
See, now you have a fungus infection in the lung. How often does the fungus infection involve the valves of the heart? When it can go to the brain, why not? What about the valves of the heart? How often does it involve them?
Yes, sir. Dissemination can occur to multiple organs. It can occur to the brain, the heart, especially the valves, the liver, the spleen, as well as the skin, sir.
Which is more common?
This
Which is more common, the lung or the heart or the brain?
Due to the closer proximity, I would assume the heart is more common.
But we rarely find fungus infection of the heart valves per se, but more often, more prosthetic valves of the valves per se is fairly uncommon in our country. Anyhow, your
Yes.
presentation was excellent. I enjoyed your presentation. Good luck.
Thank you, sir.
I'm a little curious. Why did the patient go against medical advice when the treatment was so good and he was improving so well?
Yes, sir. Even we could not understand why the patient was so adamant. We tried convincing the patient multiple times. We explained the possible ramifications of ending the treatment early. We explained the possibility of recurrence of this condition or exacerbation of this condition and recurrence of the lesions in the brain. However, the patient as well as the attendant were still strongly insisted that they wanted to leave the hospital environment. They just wanted, in their words, they just wanted to get away from the hospital and back to their hometown. So after a point, we had no choice. We had to respect their wishes. So.
Doctor, can I ask you a question? Can you hear me?
Yes. Yes, sir.
What about these other markers like procalcitonin and CRP? Does it get raised in these type of infections?
Yes, sir. Procalcitonin and C-reactive peptide are acute phase reactants that increase in levels during any infection. However, they are non-specific, sir.
In this patient, it was raised?
In this patient, the levels were raised, although I haven't mentioned that in the PowerPoint presentation, sir.
Yeah, but
I wanted to focus.
Yeah, go ahead.
Sorry,
I can
sir.
hear you. Go ahead. I
No,
can
sir.
hear
I
you.
just didn't. Yes, sir. I just didn't mention those findings in the PowerPoint presentation, sir.
Yeah, but is it not useful to know the levels of the procalcitonin and CRP during the course of the treatment? When the patient becomes better, these levels do come down, isn't it?
Yes, sir.
They help you to tell us that your treatment has been extremely useful. So you can't ignore
Yes,
you can't afford to ignore the use of these biomarkers like the procalcitonin and CRP in the treatment of infectious patients. Okay.
Yes, sir.
Yeah, it is a great pleasure hearing you, man. You're from Rajiv Gandhi, is it? Rajiv Gandhi.
Yes, sir. I'm from Madras Medical College, sir.
Okay. Oh, that's Madras Medical College. All right. Good.
Yeah.
Nice meeting you. Thank you, Dr.
Thank you, sir.
Badri, for allowing us to participate in these beautiful discussions.
So I would like to thank the panelists for taking time to sit and listen and give your valuable inputs. It has been a learning experience. So thank you all the judges, Dr. Jayavelan, Dr. Vijay Shankar, Dr. Ramasamy, and Dr. Raj Murali, and especially the Dr. Raj Murali and Dr. Ramasamy. I think you're on the other side of the world, and it's just early morning, I suppose.
Well, 8 o'clock in the morning in California.
Okay. Thank you for taking the trouble to be with us and share your experiences also and sharing your inputs. Surely it will enrich the students as well as enriching all of us. So thank you all.